Hello everyone, welcome to this scientific session you and I in Blogging Education. In this session, we would like to discuss important topic pediatric optic neuritis. Today we have with us Dr. Adli. Her research has been in pediatric optic neuritis and her work has been published in top-tier ophthalmology journals. Today, Dr. Adli will be discussing pediatric optic neuritis, a topic highly relevant to all of us in the field. I'm Dr. Muhammad, pediatric ophthalmology fellow. First of all, I would like to give brief introduction. Optic neuritis is an important inflammatory condition of the optic nerve that causes visual impairment and may herald demyelinating disease. Monophasic optic neuritis is a single attack of unilateral or bilateral optic neuritis without evidence of other CNS involvement. This case came to us suffering from loss of vision in the left eye, no perception of light. Right eye 20/20, color vision, left eye fail. Left eye, relative afferent pupillary defect grade 3. The main clinical features of pediatric optic neuritis is rapid and often severe vision loss, pain with eye movement, and abnormal color vision and visual field defect, also relative afferent pupillary defect. Children may also have more bilateral involvement compared to adults, and the optic disc may be swollen. Now, I would like to ask Dr. Adlin, how do you approach of pediatric optic neuritis?
First of all, thank you, Mohammed, for having me here in this UNI to discuss on pediatric optic neuritis. So, as you've already mentioned, pediatric optic neuritis is common demyelinating event in a child, which is seen in almost 25%. However, optic neuritis as such in a pediatric age group is relatively rare. So, we know that younger children may not be able to complain about their vision loss or pain. So, we have to look at how the child is behaving, like the visual function of the child, maybe in school or while playing, like how the child was previously and how the child is right now. So, that can be an indication of the child having a little lesser vision. Whereas, in case of an older child, the child may be able to complain about the vision loss as well as the pain on ocular movements. Another important thing that we have to be very vigilant is post fever or post vaccination, we have to observe how the child's vision is. And in cases of some other associated neuroinflammatory disorders, we have to know any associated symptoms, like in cases of infective etiology, the child can be irritable. The child can have fever, neck stiffness. In some cases, like in multiple sclerosis, there can be bladder incontinence. In cases of neuromyelitis optica spectrum disorder, there can be intractable hiccups. So we have to look at all these associated symptoms as well. So initially, the etiology as such was most commonly seen in post-infectious or post-vaccination, but of late we are seeing more inclination towards the neuroinflammatory syndromes like myelin oligodendrocyte associated disorder being most commonly seen in children, and the others being multiple sclerosis, neuromyelitis optica spectrum disorder, and the EDEM. Multiple sclerosis, as such, the incidence is much lesser in the Asian countries compared to the Western. On examination, we have to test the monocular visual acuity of the child, and whenever possible, color vision also can be seen. The pupil examination, however, it can be kind of difficult in a child, but we have to try and make sure that there is, if we have to make sure if there is RAPD or no before dilating the child. And after try checking the ocular motility and see if there is any associated pain when the child is moving the eyes. Then coming to the fundus examination, so as you've already mentioned, in children most likely the child will have disc edema and it's usually bilateral. However, we can have unilateral involvement, and sometimes the changes can be so subtle that it may be missed out. So, for that, we need other ocular investigations like visual evoked potential, where in a demyelinating event, we will see a delayed latency, which could be more than 110 milliseconds, or the interocular difference in cases of a unilateral involvement can be more than 10 milliseconds. And in cases of children, visual field test as such could be a little difficult. So, in such cases, whenever possible, we have to try and get a visual field, but it may not be possible in all children. And visual field can have any kind of defects, like it can most likely it is a central or a centrocecal scotoma, but however, we can see altitudinal like it's seen in this patient. And a very important test would be an optical coherence tomography of the retinal nerve fiber layer as well as the macular ganglion cell layer. And another mandatory test is radio imaging. That is, neuroimaging is a must to confirm the diagnosis of optic neuritis in children. And the other associated investigations that we can get is the CSF analysis whenever we are suspecting multiple sclerosis to look for oligoclonal bands, or in cases of infective etiology, also, we might need to get the CSF analysis. Getting a serology test of the antibodies of aquaporin 4 as well as myelin oligodendrocyte is also important whenever the neuroimaging is suggestive of an atypical optic neuritis, which is showing any associated neuroinflammatory disorders.
It depends on the OCT. OCT is a considered an important test for diagnosis pediatric optic neuritis. Can you, Dr. Adeline, tell us how does OCT help us in pediatric optic neuritis?
Optical coherence tomography is an important biomarker, especially as I already mentioned, getting a visual field test in all children is very difficult. Another thing is, in cases of OCT, we do not have the color codings for patients below 18 years of age. However, in literature, there are many published values which is showing RNFL to be approximately around 100 to 110 microns, and the macular ganglion cell layer to be around 80 microns. So, with keeping these as the values, we can get an OCT, which will differ again according to the machine that is used, as well as the refractive error and the axial length. But just keeping these values, we can get the OCT RNFL, which can help us in monitoring the disease. And in cases of a recurrent disease where we are not able to see the pallor as such, we can also see if there is a recurrence of the disease that is there. And sometimes it can even help us in prognosticating. So, what we see in the acute phase is the RNFL can show thickening. Following, after the acute phase has passed on, and when there is an axonal loss, we can see thinning. In cases of multiple sclerosis, it's more predominantly a temporal thinning, whereas in myelin oligodendrocyte and NMO, we can see a diffuse thinning, and NMO has severe RNFL thinning. In cases of an MGCL, it is an initial indicator, like an early indicator. So even before even the RNFL shows changes, the MGCL can show us changes. And in cases of the other eye involving and which has only unilateral disc edema, but even the other eye is involved, maybe the MGCL can be a good indicator to show if it is bilateral or a unilateral. And as well as in cases of an NMO type, the literature also says that we can see microcystic changes and severe thinning. So that can indicate, help us in classifying NMO versus the other types of optic neuritis. So basically, OCT helps in monitoring the disease, tells us of a recurrent episode, and prognosticating the condition.
I understood from your words, Dr. Adeline, that the OCT is considered an important indicator of visual function and also for monitoring the case measurement of the thickness of peripapillary retinal fiber layers, which is a very reliable and reproducible way to monitor mild to moderate optic disc swelling and increase in sectoral and average retinal fiber thickness. I'm correct, Dr. Adeline? We can move